going to open the floor for Q&A, and since the session is live on C-SPAN and being recorded, it's going to be important that you find your way to one of the microphones around the room so we can be sure to capture your questions, and also please introduce yourself before asking your question. And so I guess do as I say, not as I did when I forgot to turn the microphone on at the beginning of the session. And while you're finding your way to the microphone, I will kick it off with a first question to Steve and to anybody else on the panel who might want to discuss this. And Lisa, you touched on this. Certainly one effect of the recession and joblessness has been a dramatic increase in the number of older Americans without health insurance who are too young for Medicare. The Commonwealth Fund reports that there are 9 million people aged 50 to 64 now who are uninsured as of 2010, and that's a figure that's up from 5.3 million as recently as 2002. So my question is it possible to find the link, and what is the cause and effect relationship of that rise in general lack of coverage in health insurance and the rise in disability insurance applications? Can one actually quantify that or not? And then a second sort of follow-up piece of the question is, with the Affordable Care Act now up in the air, and one of the most important things that the ACA certainly is going to do is get many of those people covered again. So I'm wondering what the panel's thoughts are, and maybe Steve, you could start from kind of a numbers perspective as to what does the relationship look like on health insurance for older Americans?
Well, Mark, that's a really good question, and as you well point out, a very complicated one. We do, of course, have, if somebody has health coverage in their employment and they leave their employment, that they get, I think it's a 24-month continuation. They can continue to buy it, but they have to pay the whole bill. And once people have lost their job, that's difficult for people to do. One of the issues, of course, with the nature of our Social Security disability insurance program is if you lose your job, you do have impairments, you apply for benefits, you get the benefits. You not only have a 5-month waiting period before your monthly Social Security disability benefits start, you have an additional 24 months beyond that before the Medicare benefits start to come in. So clearly these contribute towards a lack of insured status. I know that many people have looked at, among other possibilities, to help improve our prospects for the cost of Social Security disability, but more importantly, to improve the prospects for people who come to have impairments that make it difficult to work, not only, as Dave mentioned and others, to try to find better, more effective ways to help people have greater work opportunity, but also to provide additional assistance to people even before starting to receive disability benefits in terms of having access to health care that might be able to maintain them in better health status.
So preventive care, having adequate coverage for prescription drugs, et cetera.
Now the Affordable Care Act that you mentioned, Mark, obviously will have big effects. And the Affordable Care Act, on the one hand, will provide people with that adequate care much more generally than we have now, and that may result in fewer people filing for disability benefits if they maintain their health status in better condition. On the other hand, it would also remove the sort of disincentive that we have now of having to wait 24 additional months to get Medicare, because people would have greater access to health care benefits. So which way that plays out exactly is not clear.
Any other comments on that? Marty?
I would just say that I don't know who has tracked this or whether you can track it, but we do know anecdotally that people do delay getting health care because they don't have the funds to go to the doctor or get health coverage when they need it, and their health conditions exacerbate to the point where they are more costly when they do finally show up, at a physician's office or at the emergency room or a hospital. Even when the Affordable Care Act goes into effect, people will need to have the ability to pay for health coverage. They're going to have to be able to pay for their plans if they're not on Medicaid. So it's still an issue as to being able to have the funding to pay for. I think the whole issue of the 2-year plus 5-month waiting period is a big issue, and hopefully will be addressed, and so people may not even need to consider Medicare. And that would be a tremendous, step ahead. But there are still issues out there, and Medicare, and healthcare is not going to be totally eliminated as an issue for people to consider in terms of their pocketbooks.
And under ACA, you'd have roughly half of this age group who would be covered under Medicaid, under the expansion of Medicaid, which is very dramatic, and the rest would be shopping in the exchanges and with various levels of subsidy for their premiums depending on income level.
Yeah.
Let's turn to the floor. And do we have anybody with a microphone yet?
Mark, if I could just
please
also just add to what Marty said, one of the things that the importance of healthcare for people with disabilities can't be understated, and or can't be overstated. And I think that when the Ticket to Work legislation was passed, Congress created an option for states to enact something called a Medicaid buy-in program, which would allow working people with disabilities to purchase Medicaid so that they could get affordable health care that really provides all the services and supports they need to continue working. And most states have taken up that option, but they allow for different levels of earnings, and some still have pretty strict resource tests. So I would say that if we, as a country, really want to address the healthcare situation for working people with disabilities, we should support a national Medicaid buy-in without a resource limit, similar to the what the qualifications now for the Medicaid expansion, that would allow people with disabilities to work, to save, to be independent in the community, and never risk losing their attachment to that vital health care and services and supports that allow them to live in the community in the first place.
And so those buy-ins occur at the state-by-state level?
They occur at the state-by-state level. Some have rather generous income limits and resource limits. Some have rather strict income and resource limits. But regardless of how much you earn or save, a person with a disability cannot self-finance the services and supports that they need to live independently in the community. So the best way to ensure that that happens is to create a program that allows people to buy Medicaid, regardless of what their income or resources is, to allow them to have uninterrupted access to the services and supports they need.
Thank you. Let's go to the floor for some questions, and we'll start right back here.
Thank you.
Please introduce yourself.
Yes, my name is Stefan Lindner, and I'm working at the Urban Institute. And I have a question to a panelist about, so the topic of this event was why has the number of people on DI increased, and what can we do about it? We heard a lot about the first question. We saw a lot of graphs about that. And then people talked a lot about reforms. But I think what was missing in this whole debate was the kind of notion that because we have this increase, we need reforms. And I was really curious to see from you whether you actually think that's right or not. Right? I mean, we see this huge increase in people on DI to 8 million people. Is this good or bad? Okay, one stance is it's good, right? Because we insure much more people. It's very important. We see that these poverty rates are very high for these people. We provide very important income benefits to them. The counterpoint is that this is bad, right? That we have a program which is expanding and we need to shrink it. And then the third, more measured view here is that it's just not related, right? We have to think about reforms independent of the size of this program. Thank you.
Sorry, this gets back to the beginning of my talk. I mean, it seems to me that the real reasons to consider reform aren't the fiscal issue and the number of people on the rolls, it's their economic status, the decline in employment. It's just harder and harder for people with disabilities to be self-sufficient or even partly self-sufficient as time goes on, and that's what the statistics show, and many live in poverty. And it seems to me that that's the fundamental reason to consider reforms.
I think I said during my presentation, I completely agree that the employment situation for people with disabilities is not good, and we need to do a lot more as a country to assist people with disabilities to go to work when they are able and up to their capacity, whatever that is for the individual. I think if you go back to one of the slides in Dave's presentation, the one area where we have cut spending, and we've seen a minus 2.6% in the time period that Dave outlined is on employment, training, and education services. And so if we're serious about helping people with disabilities go to work, we shouldn't start with the vital income support program and looking at what we need to reform. We need to look at how can we improve our special education, how can we improve the outcomes of people in school, how can we improve our job training programs, and how can we improve our employment support programs. And so my answer to that second question is there's a lot that should be done about it, but it doesn't have anything to do with the Social Security Disability Insurance Program that provides income support. That's what it does, and that's what it should do. But we should do a lot more to help people get jobs, keep jobs, and not have to apply for benefits in the first place.
Yeah, one of the problems. One of the problems that I see is even if a person gets a job, there are all these extraordinary expenses that people, particularly people with significant disabilities, have to cover. It's not just rent or mortgage and food and basic transportation. It's the personal assistance, both at home and work. It's the cost of an accessible vehicle. It's the cost of a wheelchair or augmentative communication device. These things are very valuable tools, but they're also way outside the wherewithal of many people with significant disabilities to purchase. Now, I don't know, there are some thoughts about turning the disability insurance cash flow into a supplemental income stream in order to help pay for some of these things. That, of course, would take a radical departure from where we are today. But somehow or other, either through the tax code or through additional supports, we're going to have to find a way to help people with disabilities to pay for these devices and services and supports.
Thanks, Mark. Yeah. I guess a little bit further perspective, when we talk about reforming a program, of course, there are two ways to do that. If we're projecting in the future that the cost is going to be more than the scheduled taxes coming in, one way is to try to find a way to pull down those costs. Another way is to find a way to come up with more revenue to be able to pay for the costs. We have, as I think everybody knows, the definition of disability for the Social Security Disability Insurance Program is a really strict definition, and it's applied pretty strictly. There's been some changes over time. But it still continues to be a very strict definition of disability. I think up at the retirement age where people transfer over, we have only about 10 to 15% of our population that's insured receiving those benefits. So I think going forward, that has to be something that we consider. Are we going to pay for what we have, or are we going to find ways to try to pull back on the cost on that? And I just add one little rejoinder. The numbers that I'd put up, the numbers that Dave put up, I think are exactly in consonance. Dave had the one chart where he showed that the number of disabled worker beneficiaries is maybe something like 28% higher than if the age-sex specific prevalence rates, the likelihood to be disabled, had stayed exactly the same over the last 20 years or so. Well, the difference is simply because women have had increased incidence rates relative to men. They've basically moved to parity, and both men and women have had a shift in incidence rates towards younger ages. And I would just add that one thing a lot of us would hope, I know in my office, we have some fantastic people in our office. Alice Wade, who's here, Eli Donker, our deputies who work on this stuff all the time with Dave and others, understanding more why there has been this shift towards more disability at younger ages relative to older ages would be a real step in the right direction to understand why we had the increase in cost we've had.
I guess I would just add to that, if you look at the general job market and the slack that we still have in terms of joblessness and the slack in the market, the challenge on the discrimination side seems to me to be really a big, tall hill to climb. You've got already very rampant discrimination in the workplace based on age. Disability was mentioned. We even have a lot of workplace discrimination just against people who have been out of a job for a while. So, you step back and look at sort of the marketplace conditions, I think suggests that this is a big challenge. Let's take a question right here, sir.
Yeah, good morning. My name is Nathan Dansky. I'm from the HIV Medicine Association. I have a follow-up question on your discussion about healthcare reform and its significance for the program. I suppose I'll frame it by saying, for example, 40% of people who have HIV and are receiving care are paid for through Medicaid program, but most of those people only receive that benefit after becoming disabled due to their illness. And so I'm wondering, to what extent are people who have a preventable disease or a treatable disease who have lacked health care driving disability costs, whether or not that's a factor, and whether or not healthcare reform is something that will really address that. You know, I'm wondering how big of a piece of a pie is it? Is it large or is it really small?
Dave?
I think it's really hard to put a number on it. I think it's pretty important, and the example you're alluding to is just one example of how, you know, I indicated that I think we get things backwards, right? We don't figure out what people need so they can continue to work first and get that to them. We get them into benefits. A couple of years later, we get them into Medicare. And my colleague Gina Livermore and I did a paper on the beneficiaries on their way into SSDI and into Medicare and how many didn't have insurance in that period of time. And these were data from the mid-1990s. And at that time, you know, about 15% didn't have any coverage at all. And you know, some of them died before they became eligible for Medicare, right? So what you're saying is just an example of how we have things backwards. You know, we don't figure out what people need so they continue to work and be productive. We let them get into these programs, and then we start giving them services such as health insurance.
Just want to respond to that a little bit. I don't disagree that we ought to provide provide people better services ahead of time. But again, I will reiterate that that doesn't mean we have to change SSDI. It means we have to change the other programs that make someone go apply for SSDI before they can get access to healthcare or employment supports, as opposed to changing the vital income support program that people with disabilities rely on to keep them with a roof over their head.
Let's take another question.
Hi, I'm Kathy Hurwitz with Congresswoman Schakowsky, and I kind of want to follow up on that. I was actually surprised by the two charts, David, you had on current policies failing taxpayers, defining that as essentially too many people are on SSDI. And I don't think that's failing taxpayers. I think that's a good thing as a taxpayer. I'm glad that people are getting SSDI, because without it, I don't know what would be happening to them. I assume that you're saying here not that there are too many people getting SSDI, but that there should be other things for them in the workplace. And I guess, and I hope that's what you mean. I hope you don't mean that we should take 2.2 million people and just throw them on the streets. But in terms of the workplace, I'd like to know how you think we get employers to provide not just jobs for people with disabilities, but good jobs for people with disabilities that provide good benefits and the supports that they need, particularly in this time, but in this political time when nobody seems to want to be required to do anything in the employment sector. I mean, do we require that they provide adequate health coverage? Do we require that they provide supports? I mean, how do we do this?
So I certainly didn't mean we should throw whatever it was, 2.2 million people off the rolls. And I actually agree largely with Lisa about, you know, the issue isn't reforming the SSDI program. It does provide essential benefits. I mean, I do think there are some changes we could make in the context of larger reforms to SSDI. And I think one thing that has happened is that because SSDI is the program that's available to workers when they have a problem, we've made changes to SSDI to make it easier for them and more attractive for them to work while they're on SSDI. And we wouldn't have had to do all that if we had something in front of SSDI so that not so many people were getting on the program in the first place, or something that helped them continue to work rather than get into SSDI before they could get support. As far as getting employers to be more interested and supportive of hiring people with disabilities, that's really tough to do. And the health insurance, and actually this gets back to one of Marty's comments. The paper that David and I wrote sort of assumed that the ACA would be implemented and that would be the sort of basic form of health insurance for everybody. We probably should have consulted with the Supreme Court first. But it is incredibly important. I don't think forcing employers to provide health insurance is the best way to do it, though, because that imposes costs on employers. And if they're having to foot the cost for an employee's health care and that employee happens to have a lot of health care, why would they want to keep employing that person? So I think it's very difficult to find options that would encourage employers to hire people with disabilities, but I think they have to be, we have to look at those more carefully, whether they're tax incentives or other things. People have suggested, for instance, reducing the payroll tax if you hire somebody who has a disability that's at the level that they would otherwise qualify for SSDI or SSI. So that's an example.
I guess I'd just like to add that I think in a broader context, the one possibility is, and we've talked about this in the context of as our guys like Dave and I are aging and trying to encourage people to work longer, provide tax incentives for people to work at higher ages. If that really just means that they have an edge over younger workers to get a job, that's not the best of worlds, perhaps. I would suggest the best of worlds is something that is in the broader context. It's sort of the rising tide floats all boats. And what we really need is more economic opportunity, more jobs in general. We have an 8+% unemployment rate at the moment. That's a temporary, that's a cyclic phenomenon. But I think looking forward, it really is a serious question, competitiveness, job opportunities in this country, and folks who have medically determinable impairments will always be at a slight disadvantage one way or the other. But if we have more economic opportunity, more jobs available in general, that really will be to the benefit of all of us. We'll have more taxable payroll, have more money coming in. It is sort of the route towards solving the problems for programs like this. So I think beyond just disability and what we do just for folks with medically determinable impairments, enhancing the job opportunities in this country in general would really go a long way.
Just to add to that a little, I think one of the things we could do, again, not to sound like a broken record, is to have a national Medicaid buy-in. If employers knew that the healthcare costs would not affect them, that could remove some of that misperception and fear. I think another thing that we can do is encourage the federal government to fully comply with the executive order on hiring people with disabilities in the federal government. One of the biggest ways that we can encourage employers to hire people with disabilities is to show them what good workers people with disabilities are, the fact that they have lower absenteeism, generally have at least as high productivity as their non-disabled peers, and the best way we can do that is to lead by example. And if the federal government were to become a model employer of people with disabilities, it would do a lot to help educate employers about the truth of workers with disabilities. And if we could also have their health care taken care of, it would remove a lot of the fear and anxiety around hiring people with disabilities.
Let's go to another question on this side of the room.
Thank you. Good morning. I'm Winthrop Cashdollar with America's Health Insurance Plans. I really appreciate and enjoy the robust and interesting discussion this morning. Going back a ways, a question for Mr. Goss about the rise in the disability population in recent years and an outlook for the future. The question basically is, you mentioned the Great Recession. You mentioned, both you and Dave mentioned the changing participation of women. But are you able to offer an opinion on whether you think that some of the rise is actually a success story in dealing with certain disabling conditions, cancer, HIV, that we've progressed to a point where their survivorship is strikingly higher, and perhaps there's a way to progress even further to a point where work capacity can be preserved and maintained?
That's an extremely important question, and in one sense, what you're saying is exactly right. we have had a success story in so many areas where there are disabling conditions of maintaining people with sufficient health to survive, to continue to live and live a good life, even if not able to recover to the point of being able to go back to work. And that has contributed towards people who come on our disability rolls, staying on the disability rolls, surviving longer. And certainly that increases the prevalence, the percentage of our population that's receiving disability benefits. In that sense, there's no question, but it's a success story. Just as I think we would probably agree that once people reach 62 or 65, if they live longer, that will most certainly increase the cost of our retirement program. But hopefully we'd all agree that's a success story if people live longer after they reach age 65.
Good morning. My name is Glenn Shore with the U.S. Department of Labor. And I've got a question that gets to the main question of why are more people claiming. And I wonder about these substitution effects that might happen. Some people talked about the rise in the retirement age as being one reason, health insurance going away for some people being another reason. And I'm wondering if anybody's investigated the devolution of other social insurance programs like workers' compensation and other things where the state reductions in benefits might be causing some of the increases in DI costs.
I'll mention a couple things. One is welfare reform, which the law was passed in 1996, I believe, and there's been quite a lot of research on the effect of welfare reform on low-income parents obtaining disability benefits, mostly initially SSI, but to the extent that they've had some work experience, and for fairly young people, it doesn't take a lot of work experience to qualify for SSDI. So I think part of the rise in the disability incidence that Steve has pointed to for women could be, and for younger people, could be explained by the welfare reform. But it may be a fairly small amount. Workers' compensation, there's an interesting controversy about the research in that area. There have been a couple of papers published, one that finds that tightening of workers' compensation, state laws and workers' compensation, tightening of eligibility and reduction of benefits has increased the number of people on SSDI. There's another paper that finds no relationship. And it's very difficult to tell which is correct, but I think it's an important thing to think about. And certainly when people have studied changes in disability policy in other countries, they often see there's a ripple effect in other social insurance systems. So for instance, there was a tightening of eligibility in Austria, I guess in the early 2000s, for older workers, and they have something that's equivalent to our vocational factors, and they increased the age of eligibility for the vocational factors, and they found that more people worked at that age level, but they also found that more got unemployment insurance or other types of benefits from the government. So that is an important issue.
To your very good point about substitution effects, we actually have one of those that operates right within the Social Security program. When we raise the normal retirement age, which Lisa mentioned we've already gone up 1 year and we'll go another, for the benefits that are available, say at age 62, if you take your retirement benefit, drop from, it used to be 80% of a so-called full benefit, the benefit you'd get if you wait until the normal retirement age, down to 70% once we get up to an age 67 normal retirement age. However, if you start to receive disability benefits, you get the full benefit without those reductions. So shifting the retirement benefit 62 from 80 down to 70% clearly provides an incentive for people to be a little bit more inclined to apply for the disability benefit if they may qualify for that. And we take that into account in our projections into the future and certainly see that that has happened so far.
I just want to point out that it's not going to be a complete transfer of people from one program to another, though. The Social Security test is very difficult. It's a very high standard to meet. You have to be unable to perform substantial gainful activity due to a physical or mental impairment that will last 1 year or result in death. So not everybody who is on the other programs is going to be able to meet that high of a standard to qualify for Social Security. So it is not a one-to-one transfer from other programs into Social Security or SSI.
I don't see any more people at microphones, but I do have one more question for Steve. And if anybody else does have a question, please head for the microphone, and we'll start thinking about wrapping up. But Steve, a question for you about this discussion in the broader context of Social Security reform, and specifically the retirement program. Periodically, when we hear proposals for further changes in the OASDI program, we hear about the idea of yet another increase in full retirement age. What would the impact of that be on the disability program? How do the two interact, and do you really make meaningful gains, quote unquote gains, by a reform like that insofar as what it might do with disability?
Really good question. Usually when we look rightly or wrongly at reforming or changing, having legislative changes to the overall Social Security program, we usually look at the two trust funds on a combined basis, even though they are legally separate entities. Lisa was exactly right. When we raise the normal retirement age, one major thing happens. Instead of only paying people out of that fund up to 65, we're now paying them out of that fund up to 66, an extra year. Well, that extra year of benefits that is paid out of the Disability Insurance Trust Fund is 1 year less that's paid out of the Old Age and Survivors Insurance Fund. So it's kind of a trade-off, and that doesn't make a huge difference. What does make a bit of a difference, though, was the substitution idea that we were talking about before. When we do raise the normal retirement age, I mean, think of it, when you raise the normal retirement age by a year, if people decide to take their retirement benefit exactly the same age they would have otherwise, it lowers the benefit by about 6.5%. Or they can delay starting their benefit by 1 year, get the same monthly amount, but for 1 year less, which lowers their lifetime benefit by about 6.5%. So raising the normal retirement age clearly does save money overall, but there's a little bit of an offset on the disability side just by virtue of the fact that ages 62 up to the normal retirement age, the disability benefit becomes a little bit more attractive financially as compared to taking the retirement benefit. And that offsets a little bit of the savings for retirement age, but the net effect of raising the retirement age clearly is a significant savings.
And is administrative cost an issue, just with all the administrative procedure that goes into applying for DI as opposed to the almost automatic way that you apply for retirement?
There is certainly that. There's no question. The administrative costs for disability benefits are significantly higher, clearly, than for retirement benefits because of the work that has to be done in making the determination. So there is some cost in that regard.
If I could just add a couple things to that. There's also discussions about not just increasing the full retirement age, but also the earliest eligibility age, which is currently 62. And I think there's been a lot of concern about that precisely because of people with disabilities, and not so much that they're going to end up on SSDI. And in fact, some people would suggest maybe we need to make it easier to get on SSDI for those over 62 if that were to happen. But because there are many people who experience medical problems in their 50s, early 60s, that really find it hard to continue to work, and they're using early retirement benefits because they really are having a hard time continuing to work. And I think that some of those people would get into SSDI, but some of them would not. So I think one of the important issues for people with disabilities, if there is a retirement policy reform like that, is what do you do about those individuals? And there are various ideas. We had suggested an increase in the earned income tax for people at that age, some kind of a health benefit depending upon what happens with the ACA. But there are various things you could do to address the issues with that population that I think would be important to do in the context of a retirement policy reform.
Tom?
Tom Bethel with the National Academy of Social Insurance. Question for anybody. On the composition of the SSDI population, has there been a marked change in the ratio of mental health-related disabilities to physical disabilities? And is anyone tracking that in terms of relationship to economic conditions and perhaps also to what Lisa was saying about the absence of programs to help people not be on SSDI? Anybody?
Well, Tom, really actually had a couple of very colorful slides in the presentation earlier, but we just didn't have time to get into them. As it turns out, this question has arisen before, and we looked at it very carefully. It turns out if you look at people who start to receive disability benefits at any given age, younger people coming on our rolls, there's a greater proportion of them that come on our rolls with a primary diagnosis of mental illness as opposed to more physical determinants of disability. But what we've found is if you look at people at age 25 to 34, that the percentage of them coming on the rolls that are mental and other reasons has been pretty stable over the last 20, 25 years. That's true for higher ages also. There's a much greater proportion of musculoskeletal impairments for people over 45 as opposed to mental. The mental impairments dropped down quite a bit. But the distribution of reasons for disability have been quite stable across the ages. Where things have really changed, though, is the item mentioned before, that we've had a relative shift in the average age at which disability incidence occurs. We've had more people coming on our rolls at younger ages because people coming on the rolls at younger ages tend to have a higher likelihood that they'll come on with a mental impairment. And when people come on at younger ages, they have the prospect of staying on our rolls a long time until they reach age 66. Overall, we've had an increase in the share of our disability population with mental impairments.
There are no other comments. I think we're going to wrap up. I want to thank this terrific panel for their comments and thank you for attending. Thanks to C-SPAN for covering the event. Let me remind you all to fill out your blue evaluation forms and turn them into a staffer before you leave the room, to check the resource table on the way out. And I believe that you can also find presentations and other resources about today's event at the NASI website, probably sometime this week, I would guess, at nasi.org. And thanks to everybody.